Well, y'all, I'm going to go ahead and just get us started. And as people, if other people are able to join, hopefully they can just jump on. And um, we wanted to welcome you today to the UNC Injury Prevention Research Center's monthly webinar series. Today we're hearing from Professor Sumaya Mall, who's an epidemiologist at the Division of Epidemiology and Biostatistics in the School of Public Health at the University of Witwatersrand, Johannesburg, South Africa. She teaches epidemiology to master's and PhD students and also mentors a number of graduate research students. She has a research interest in the areas of childhood adversity and psychopathology and physical health in adulthood, both in the general population and in disabled populations. She also has a research interest in measuring health inequality. She's published over 60 peer-reviewed publications, and in her spare time, this is interesting. Sumaya is a heated yoga fanatic and prolific reader. She also loves cooking and spending time with family and friends. That's so lovely. Well, welcome, Sumaya. We're really excited to have you present. Again, in this series of different monthly webinars, we're trying to cover various different topics and, Sumaya's interest in childhood trauma. And just for those listening, childhood defined as under 18, those under 18. So we're interested to hear some of your work. Thanks so much. And Sumaya, I don't know if, depending on you, whether you want to engage questions along the way, or would you prefer to have everybody wait with their questions until the end?
No, I love questions as we go along. That would be really
Okay,
nice.
super. Okay, great. So if y'all have questions, please feel free to jump in and we'll try to end promptly at 12:30. So, okay, thanks so
So
much.
I'll probably talk for about the talk's probably about 15 minutes, the actual presentation. It's just a paper in
Okay,
progress that we're working on with Marie, actually. So,
fabulous.
okay, so I'm
Okay,
just going to minimize this and you can all see the slides.
yes.
So the title of the presentation or it's like a paper in progress actually. And thanks very much to Steph and Carol for inviting me. Um, it's entitled The Relationship Between Chronic Stress and Chronic and Infectious Disease Comorbidities Among Adolescent Girls and Young Women in Rural South Africa. So even though I'm the presenter, there are a number of co-authors who've done a great deal of work. Lamisa, one of our students who Marie and I co-mentored for her master's here at Wits, she's done a lot of the writing. Marie's been the principal analyst, and we're really a team trying to get it all together. But I'm really grateful for the opportunity to present it and to gauge some ideas. Okay, so even though I tell my students to not put the aims of the presentation for a conference first, I did this because I wanted to sort of give an overview of what we're doing. So it's actually really an area that I'm almost quite new to, and I feel like Marie, as a research collaborator, has really introduced me to this area of looking at elevated stress responsive biomarkers. So I think there might be some of you in the audience who are quite familiar with the CRP protein, and then, of course, the herpes simplex virus and cytomegalovirus, which can be potentially reactivated in experiences of adversity. Because my previous experience has really been around measuring trauma, so measuring both childhood and adult trauma, and looking at sort of health outcomes, either psychopathologies or physical illness. But this idea is actually really looking at it's a bit of immunology. But the epidemiological side comes in because the paper aims to measure these across two time points, and I'll say a bit more about the study design a bit later. And as well as comorbid non-communicable diseases, specifically hypertension and elevated body mass index among adolescent girls and young women in a context characterized by high HIV prevalence. So there's quite a lot of material going on here, and I'm going to unpack some of this throughout the presentation. So, we said that HSV and CMV are potentially reactivated in experiences of stress, but they're also linked very strongly to social determinants of health, and they can be proxies for adversity. So if people have very little assets, that could be a stressor. Very little food insecurity, I mean, very little food security in their households. I think hunger can also be a stressor. A lot of literature suggests that. Then also depression can be comorbid, or losing a parent or a caregiver. So orphanhood can also be a stressor. And I think what's why I put this slide first is I think what's quite difficult is to elucidate how these traumas, which I'm going to get into a little bit further in the presentation, actually overlap, I think, with a lot of adversity. So, as I said, all of these, acid index, food insecurity, losing a parent, they can all be conceptualized as kind of traumas or stressors. But we've actually accounted for these social determinants of health variables in the analysis, and that's actually some of the results that I'm going to show, and look forward to some feedback from you as we are working on writing this up as a manuscript. Okay. So let's get into what traumatic events are and how they might be related to what I've just shown on the previous slide. So traumatic events are an umbrella term for experiencing direct or indirect trauma. So you might witness a trauma. So you could witness somebody getting beaten or sexually assaulted or something like that, and that would be a slightly less direct trauma. Now, I'm sure a number of you in the audience are familiar with the World Mental Health Survey, because the head office of the World Mental Health Survey is actually at Harvard. And they work in a number of countries, developed and developing countries, and they examine about 29 traumatic events, and their analyses examine to see if these are clustered. So I've actually been quite influenced in my own analyses by what is done in the World Mental Health Survey, and because their South African Stress and Health, or SASH study, was actually done in this country. So it's been quite an important seminal study for me and other epidemiologists working in the psychiatric area. So traumatic events can occur over the life course from childhood to adolescence to adulthood, and they could include sexual, physical, or emotional abuse or neglect, and also natural disasters. Okay, so floods, famines, people, we'll see an influx of refugees in relation to a number of conflicts in different parts of the world. So they've fled also natural disasters. And Steph read my bio and said, I'm interested in how these traumatic events during childhood, adolescence, and adulthood are linked to both psychopathology and to physical illness in adulthood. But it does become a little difficult. I think childhood traumas are a little easier to measure because they would have come earlier, because they've occurred in childhood. But if you're working with an adolescent sample and you're asking about their childhood trauma, there is a possibility that these things are still ongoing. Okay, and then psychopathologies examples include mental disorders, schizophrenia and bipolar. There've been studies looking at trauma in both of those disorders, but also post-traumatic stress disorder, which needs a traumatic event. So this is just some of the areas that we're able to look at across these studies. Okay. So let's get to Africa. Okay, the African continent. Right now, I'm sitting at the tip of the African continent. So there have been a number of traumas on the African continent. There have been civil wars, there have been famines in a number of countries. Somalia is one example. We read a lot about the civil war in Darfur. And where I am, my country, South Africa, has had an apartheid era, which was categorized by systematic oppression against the majority. Okay, so I'm sure you've all learned a lot about it. Structural racism, and also violence against activists who oppose the regime. So also what's quite critical, because this is related to the research site where our work is set, and I'm going to talk, I'll show you exactly where it is the creation of homelands or Bantustans, which basically in the 70s and earlier than that, banished Black Africans to the periphery, so to rural areas where health service access and access to education was very poor, and they were actually promised autonomy and like a nationhood, but actually it just meant that the government wasn't going to worry about their healthcare or and deny them education and a number of other civil and social and economic rights. And actually, I mean, yesterday, quite fitting, was actually the anniversary of Nelson Mandela's release from prison, which was in 1990. And around that time, when he was released in prison and started to look at the country and where it was going to go, there was, for example, a major HIV explosion in the Transkei, which is also a former homeland. So, these are linked to kind of a lot of health context in which we work. Okay, so this is a map of South Africa. I'm sure a number of you have traveled here. I know certainly Steph has and Marie has. But where my arrow is, it's not very clear, but this is the Mpumalanga region. So I'm in Johannesburg. But this is the Mpumalanga region, which you could, if you drove, you'd probably take about 5 or 6 hours from Johannesburg to get to this province. And we work in Bushbuck Ridge in Mpumalanga, which is a very, very desperately poor area. And it's also a former homeland. So it's got that context that I've just illustrated. Okay, so we've said that this presentation is about adolescence and trauma and where do they fit in. So adolescent girls and young women experience stressors. Okay, they're often vulnerable to sexual violence. They may have been orphaned, in the African continent. Orphanhood is sometimes related to death of a parent from HIV, a number of other causes, of course, if you look at mortality data, but also at a very critical time of their development. So they could be at risk of intimate partner violence. And if there are these adverse living conditions and food insecurity that I've mentioned, you can imagine an experience when your brain is developing and you're feeling quite confused. Then these sorts of contexts might add to that sort of turmoil. And we're also trying to look in our cohorts at intergenerational trauma by combining older adults and the teenage and adolescent girls data sets. But data from the Northern Hemisphere and also from Australia suggest intergenerational trauma. So you might think that these adolescents, they weren't born during the apartheid era. They were born way, way after the demise of apartheid. But the legacy of inequality exists, and there might also be intergenerational trauma. It's just that it hasn't been very well explored on this continent, and certainly not in South Africa. And I hope that we will also have a paper looking at intergenerational trauma. It's partly due to epigenetics, and there are other routes of transmission as well. And these sorts of stresses, again, can be linked to the adverse physical health outcomes and psychopathologies. But in adolescence, I mean, hypertension is not often very high in adolescent samples. In fact, in our region, it tends to be quite low. But something like obesity, which is a risk factor for cardiovascular disease, potentially could also be related to stressors. And of course, infectious diseases, which is what we're looking at here. So, we've done quite a lot of research, Lamisa, Marie, and I, for this paper. And what we've read is that the experience of stressors could manifest biologically through the elevation of the stress responsive biomarkers, as I mentioned earlier on. So the C-reactive protein and the potential reactivation of CMV and HSV1. These serve as proxies for immune function, okay, and vulnerability to infection, and they have been found to be associated with traumatic events, and stressors. So studies from Australia and Brazil, in particular, have suggested a link between CRP and the metabolic syndrome. So hypertension and type 2 diabetes would be part of the metabolic syndrome. So it was worth actually testing some of these analyses based on literature. Okay, so let's talk about our study now and the actual methods. So this is a primary study that Marie and Audrey Pettifor and several of our other colleagues designed and were involved in. And it was a randomized control trial, actually, where young girls were given a conditional cash transfer intervention to determine if providing cash, conditional on attending at least 80% of school days, reduced these young women's risk of HIV acquisition. And There've been a number of data collected in this RCT, so not only data on HIV and infection, but also on trauma and traumatic events. So there were scales and mental health scales that were actually delivered, and both Lamisa and Sianda are master students at Wits that Maria and I have worked with, who have they've looked at the trauma data, so both the childhood trauma and the PTSD. So it's quite a rich data set in that regard. And since study completion, the participants have been followed for 4 more years post-intervention, and each visit included an audio computer assisted self-interview assessment with self-reported information on sexual behavior and HIV and HSV2 testing. Okay, so we in our analytical sample, so this is a secondary analysis taken from the RCT. We examined a sample of young women in this HPTN trial who had stress biomarker data recorded at 2 time points. So it's quite valuable to have the 2 time points. Dry blood spot samples were tested for HSV1, CMV, and CRP among all young women included at this time point. But in a separate case cohort study, that was done to assess the association between stress-responsive biomarkers during adolescence and incident HIV over the entire study period. We also tested samples from an additional 985 adolescent girls and young women at enrollment from the first enrollment visit for stress-responsive biomarkers, HSV, CMV, and CRP. So controls in the study were selected, 891, by taking a random sample of participants from HPTN 068 at baseline who were HIV negative, regardless of whether they later became a case, whether they tested positive for HIV at later visits. And the cash transfer or the randomization arm, it was also analyzed as a potential confounder. Okay, so I'm presenting some of the results. So this is just a table of stress biomarkers and enrollments at follow-up in 2019 in the sub-cohort that I mentioned. So you can see how it's presented, the tertiles of the CRP levels, then the CMV and the HSV1, and OD is optical density. So, I mean, these numbers, they're just presented by category, both at enrollment and post-intervention. Okay, so then I've presented some of these results as a text because I wanted it to be a bit more like a conversation, and having a table on the slide it didn't look so clear. But because we're interested in some of these social determinants, as I mentioned, of health, I thought that this could present quite an interesting forum for discussion at a platform like this. So orphanhood was reported by 21% of individuals with consistently high CRP levels, compared to 20.3% in the non-high CRP group. And that means that at both time points when we say the consistent. Similarly, depression was present in 19.6% of those with high CRP levels, slightly higher than the 16.0% in the non-high CRP group. And in terms of ever experiencing IPV, 20.7% had experienced IPV in the high CRP group compared to 16.8% in the non-high CRP group. Recent IPV in the last 12 months was reported by 12.0% in the high CRP group versus 10.9% in the non-high CRP group. Food insecurity was reported by 29.3% in the high CRP group compared to 33.6% in the non-high CRP group. For household wealth, 31.9% of the high CRP group were in the higher wealth category. Now, remember, we're actually talking about quite a desperately poor community. So maybe just these, I think wealth might be a slight exaggeration. They're just slightly less poor than others because this is very, very poor. compared to 16.3% in the non-high CRP group, suggesting that those with higher socioeconomic status were categorized in the higher asset quartile are more likely to have persistently high slide. So if we consider the CMV levels, as you saw laid out in the first table, orphanhood was reported by 16.9% of individuals in the higher CMV level group compared to 24.3% in the lower CMV level group. Depression was present in 18.2% of the higher CMV level group, slightly higher than the 16.0% in the lower CMV group. And IPV was ever experienced by 17.7% in the higher CMV level group compared to 16.2% in the lower CMV level group. Recent IPV was reported by 10.4% in the CMV lower group, the CMV higher level group, but that's higher than in the lower CMV level group, higher than the 8.1%. Food insecurity was substantially higher in the higher CMV level group at 39.6% compared to 30.6% in the lower CMV level group. For household assets, 20.7% were in the higher assets category among those with higher CMV levels compared to 22.4% in the lower CMV group. And then to move on to HSV now. So orphanhood was reported by 20.0% in the higher HSV1 level group, similar to 19.1% in the lower HSV1 level group. Depression was present in 12.7% of the higher HSV1 level group compared to 16.2% in the lower group. IPV was ever experienced by 13.6% in the higher HSV1 level group compared to 20.6% in the lower HSV1 level group. Recent IPV was reported by 6.1% in the higher HSV1 level group versus 12.4% in the lower HSV1 level group. Food insecurity reported by 30.3% in the higher HSV1 level group versus 35% in the lower group. For household assets, 22.7% were in the high wealth category among those with higher HSV1 levels compared to 20.9% in the lower HSV1 level group. So this is where we sort of get a little bit more deeply into the comorbidities. But among those with high CRP levels in both 2012 and 2019, 65.2% had a high BMI in 2019, substantially higher than 33.5% in those without persistently high CRP levels. Regarding blood pressure, 3.3% of individuals with high CRP levels had high blood pressure, slightly higher than 1.8% in the non-high CRP level group. For HSV2 prevalence, 35.9% of individuals with high CRP levels were HSV2 positive, compared to 18.7% in the non-high CRP level group, suggesting that persistently high CRP is associated with high BMI, high blood pressure, and HSV2 prevalence. Among those with medium or high CMV levels in both 2012 and 2019, 40.9% had a high BMI in 2019 compared to 47.7% in those without persistently high CMV levels. So high blood pressure was rare in both groups, with 0.5% in the higher CMV level group and 1.7% in the lower CMV level group. And for HSV2 prevalence, 26.3% of individuals with the higher CMV level were HSV2 positive, similar to 24.5% in the lower CMV level group. Among those with medium or high HSV1 levels in both 2012 and 2019, 39.4% had a high BMI in 2019, compared to 43.7% in those without persistently high HSV1 levels. High blood pressure was not observed in the higher HSV1 level group, while it was present in 2.6% of the lower HSV1 level group. For HSV2 prevalence, 34.8% of individuals with higher HSV1 levels were HSV2 positive, compared to 20.0% in the lower HSV1 level group. Okay, so this is an adjusted table. So finally, a risk ratio and confidence intervals for the association between high biomarker levels in both 2012 and 2019 and the health outcomes in 2019 among the sub-cohorts that I mentioned. And you can see at the bottom of the table that these are adjusted for age, the randomization arm, as I mentioned earlier, orphanhood, food insecurity, and HIV status. So what's quite a striking one is the high BMI that's associated with medium or high CRP in both 2012 and 2019. So that's quite a striking result. And there's as you can see, also HSV2 prevalence in 2019 is quite a striking result. As is the medium or high HSV1 in both 2012 and 2018. But that's a risk ratio of 0.97, but conceding that the sample size is quite small. So we don't have much clarity with that result. And this one, the adjusted risk ratio and 95% confidence intervals for the association between high biomarker levels in both 2012 and 2019 among the sub-cohort. So again, also adjusted for age, randomization, arm, orphanhood, food insecurity, and HIV status. But if you look at the asset index in particular, that's quite an interesting result. So the highest of the asset index, if you think of 5 quintiles, the highest of 2.25, there we are, is associated with medium or high CRP. So also quite an interesting result. And some of the others that we've seen.
Hey, Sumaya, we probably
Yes.
need to wrap up in the next couple minutes.
Okay, sure. Okay. I'm nearly done. Okay, so this is my last slide. So I think so we had a lot of descriptive results, and then we also have some of the regression of results that we're working with. I think that some interesting results are that food insecurity was substantially higher in the higher CMV level group at 39.6%, and that high CRP at both time points was associated with high BMI and HSV2 prevalence in 2019. But it's interesting that the higher acid index is associated with medium or high CRP. And I think the sort of point for discussion, because we're still writing the discussion of the paper, is actually to ask ourselves how useful some of these measures are. So an acid index in a desperately poor community, is it actually useful to measure this kind of inequality? Because to me, that's a slightly counterintuitive result, that it's higher higher acid index would be associated with medium or high CRP. And then food insecurity, also substantially higher in a higher CMV level group. I think we could introduce better measures for food insecurity, because we currently have quite minimal questions. We don't have a full scale for food insecurity in the study. And perhaps as we move forward, Maria and I are working on a grant with some of our other colleagues, where we want to assemble a new adolescent cohort. So also to look at stress biomarkers and chronic disease. So maybe we could consider some of these scales as more extensive. But I'd be interested to hear what the group think. Thank you.